Can everybody see that okay?
Yep.
Okay. So for my case presentation, I want to talk about a case I saw in my pediatric rotation about a couple of months ago. And it was a 10-year-old boy, previously healthy, just had a mild COVID infection in February 2021, just some respiratory symptoms, and he recovered in a week or so. And then about a month later, he started developing spells of feeling dizzy, falling to the floor. And he ended up in the ED after what sounds like a right-sided focal seizure, was started on Keppra, and was discharged home. Over the next month or so, he started developing worsening seizure despite increasing Keppra, to a point where he was hospitalized for status epilepticus. And it was to a point where he was in the PICU, started on Versed drip, and was put in under coma. And this was all sort of thought to be secondary to post-COVID inflammatory syndrome. And he was treated with prednisone and IVIG, which stopped the generalization of the seizures, but he's continued to have focal seizures on the right side. Let's see. So this was the initial MRI, which showed that you can see there some flare changes on the left motor strip that corresponds to diffusion restriction on that side. And that corresponded to his right-sided seizures. And despite starting him on all of these AEDs, he continues to have focal seizures. So they decide to do the left parietal craniotomy to remove the epileptic focus. And the biopsy of the lesion showed no neoplasm, but a lot of inflammatory changes like reactive gliosis. They could not control, completely get rid of his seizures, so he was eventually discharged to rehab, and VNS was placed after discharge. So fast forward a couple months after discharge, so we're in October now, he continues to have focal seizures that's worsening, so he comes to Duke DD for sort of second workup, and initial exam showed, intact dentation, but he's weaker on the right side, possibly due to ongoing seizures versus recent, the surgery he had. And he was noted to have the rhythmic jerking of the right side continuously, sometimes involving his right side of his face. So here he was treated with 5 days of high-dose IV steroids without much improvement. And he underwent repeat imaging and a second biopsy to confirm the initial diagnosis. So this is the second MRI. So this is about 6 months after the first one that we saw. And you can see now it involves sort of more medial aspect of the left motor strip. And I remember talking to the radiologist about it, and they sort of described it as a chunky appearing lesion there. And this could be secondary to either postictal change, given a seizure history, or much less likely, but possible, is another one's low-grade glioma. So he underwent a biopsy of this lesion, and again, no signs of vasculitis or neoplasm, but a lot of inflammatory changes, including reactive gliosis, mononuclear inflammation, and autoimmune encephalitis panel was negative. So he was diagnosed with Rasmussen's encephalitis. This was first described by Canadian neurologists in 1950s, and mostly occurs in children, young adults, median age of 6 years, and very rare, just 1 to 7 per 10 million. And pathophysiology is thought to be driven by T-cell response to antigenic epitopes. But so far, no causative virus or antigen has been identified yet. And so typical clinical features are unilateral inflammation of cerebral cortex, which we saw in our patient, and drug-resistant epilepsy, and progressive neurological cognitive deterioration that occurs over the course of a year or so. And almost half the patients have EPC, which our patient did. So the goal of the treatment of this disease is to reduce the seizure severity and frequency and to improve long-term outcome. For the first goal, hemispherectomy is the only cure for seizures. There are trials with immunomodulatory treatment that can hopefully slow progression. And these are unfortunately small, uncontrolled due to how rare this disease is. But right now, sort of standard treatment is to undergo steroid, IVIG, Plex, which have shown some positive results. And the other treatments that were studied were tacrolimus and azathioprine. They were picked mostly because they are T-cell inactivating treatments. So for our patient, currently he was recently discharged about 2-3 weeks ago, and anti-epileptic medications and VNS have sort of prevented the generalization of the seizures, and family is in talks with neurosurgery about possible hemispherectomy at this time. Okay, so these are the sources I looked up, and that's the case I saw about a couple of months ago. All right.
Thank you, Justin. Thank you so much. All right, everyone. We're in for a real treat today. We have Dr. Sneha Mantri is going to be doing grand rounds. Sneha is assistant professor of neurology, and she's also the director of the program in medical humanities at the Trent Center for Bioethics, Humanities, and the History of Medicine. And Sneha, as I was walking over from my morning coffee, I actually found out where that is. It's in the Searle Center. Didn't know that before. Sneha has her MD from Columbia, fellowship in movement disorders at the University of Penn, and did her residency at the University of Virginia. And Sneha is going to talk to us today about Thrive PD, a new care model for people with Parkinson's disease. But it probably would work with AD as well, right, Sneha?
I definitely think it would. I think it's the way of the future when we think about caring for people with degenerative conditions. Thank you, Rich, for that kind introduction, and great case, Jung. Very interesting, but also devastating. It sounds like for the child and the family. I also want to echo Rich's welcome to the applicants. I'm looking forward to meeting with many of you later today. But for now, I want to kind of talk with everybody about this way of thinking about caring for people with Parkinson's that we've begun to implement here at Duke. And, especially as Rich alluded to, think about ways that this could apply to other neurological conditions or degenerative conditions that we see in our clinics across the health system. So slides will advance. Here are my disclosures. In particular, a lot of this work was supported through a grant from the Clinical and Translational Science Institute. So, Parkinson's disease, I think, has a number of different challenges when we think about how we're taking care of people with PD in the 21st century. In particular, I'm going to go through each of these in more detail, but as a high-level overview, there's increasing prevalence and patient volume of people with Parkinson's disease. Simultaneously, there's an increasing cost burden, both to the health system as well as to individual patients and families. There's a real lack of access to skilled professional services, both movement disorder specialists, general neurologists, and in particular rehabilitation therapists, in part because of this cost burden and patient volume. And so ultimately what that leads to is a real fragmentation of care for people with Parkinson's. And as you might imagine, that in turn leads to poor patient outcomes. So I'm going to show you some evidence for each of these factors in turn, and then we'll talk about sort of what our solution or one potential solution here at Duke has been. So the incidence of Parkinson's disease has really been rising significantly over the course of the second half of the 20th century, especially in men more than women. This is a graph of incidence of Parkinson's per 100,000 individuals. And what you can see in the blue line of men. In 1975, there was maybe about 17 per 100,000. And that rose over the course of the year. There's obviously within each study a lot of variability, but there's this real secular trend for men, less so for women with Parkinson's disease. And it's not entirely clear where that gender disparity or gender discrepancy comes from. One potential thought is that women may be hormonally protected from some of the effects of Parkinson's disease. Women are certainly less likely to be diagnosed with Parkinson's for, again, a whole host of reasons. But this increase over the second half of the 20th century is, increasingly felt to be attributable to environmental risk factors, in particular the use of pesticides and other chemicals that may impact men occupationally more so than women. Simultaneously, over the last 50 or so years, there's been an increase in life expectancy after the time of diagnosis. These numbers here are for a 65-year-old man diagnosed with Parkinson's disease in 1967 would, on average, be expected to live about 9.5 years. By 1993, that had risen to 13.1 years. And the most recent data I was able to find from 2020 was 25 years from the age of 65. So really that, would potentially take somebody to age 90. And so what that combination means, the increasing incidence and the increasing sort of disease duration, leads to a real explosion of Parkinson's prevalence across the country. And you can see from this data from the Parkinson's Foundation that it's sort of unevenly distributed across the country. There's a little bit of a preponderance in Rust Belt states out in the West, and increasingly in the Southeast. Here in North Carolina, there are about 24,000 people living with Parkinson's disease. Here at Duke, we take care of about 10% of those people, close to, I think the most recent numbers were 2,200 patients, unique patients per year seen with Parkinson's in 2019, just before the pandemic. And so part of that increasing prevalence means that there's really this rising cost of care for people with Parkinson's. It's hard, at least for me, to think about the big numbers, billions of dollars that are spent on Parkinson's per year. But if you break it down to an individual patient, again, on average, with acknowledgement that there's a lot of variability from place to place and depending on people's insurance, a person with Parkinson's in a year will spend about $24,000 on direct medical costs. These are things like medications, co-pays for doctor's visits and physical therapy visits and so on. They will spend about $18,000 on what's called indirect medical costs. So these are like transportation to the visits and other services that people partake of. And then about $7,000 in non-medical costs in a year. This is things like outfitting your house for grab bars and wheelchair ramps and so on. So that works out to about $50,000 a year, split between insurance costs and patient out-of-pocket costs. In North Carolina, we found that the numbers are essentially CMS, the Centers for Medicare Services, pays about $16,000 per year for people with Parkinson's, and the out-of-pocket costs for patients are on average about $2,500 per year. So you can imagine that somebody who's older, living on Social Security income, this is a pretty significant cost burden for patients and families. And in part, I think because of that, there's this real disparity in lack of access to skilled medical and therapy services. Less than 1 in 3 people with Parkinson's disease receive PT or and or OT services within 3 years of their diagnosis, which is really, really unfortunate because we know that early access to skilled services are one of the biggest things that can benefit people early in the disease. You can see here in North Carolina, we're kind of in the middle tertile across the country, but when you actually look at the numbers, you know, it's really only about a quarter of patients in our state get early access to PT and OT services. Interestingly, that lack of access doesn't really track with low supply of providers. You can see in cross-hatching states that are in the bottom tertile of supply of PT and OT providers. So this really kind of, I think, points to differences in referral patterns, perhaps difference in insurance coverage of different types of services and so on. The biggest predictors of lack of access were race and ethnicity, particularly for Black and African American patients, had a significantly lower rate of access. Increasing age, with people in the older age groups not getting referred early. And then people who were not being cared for by a neurologist, so people who were seeing perhaps just a PCP or geriatrician, who were, I think, really, really important providers for a lot of patients with Parkinson's, but perhaps don't have the same referral networks and ability to get people into PT and OT early. So I think that those three factors really, I think, point to, potentially intervenable opportunities to get people access to care as early as possible in the course of the disease. Ultimately, what a lot of this is leading to is a fragmentation of care. It's very difficult for people with Parkinson's disease and their care partners to communicate adequately among the various specialists that they see, whether it's a movement specialist, GI doctors for constipation, ENT physicians. There's just there's this real perception on the patient's part that it's not appropriate, perhaps, or they don't want to, particularly care partners don't want to speak about psychosis or dementia in front of the patient. There's a perception from care partners, we found, that they feel like they're telling, quote unquote, on the patient, even though these are aspects of the disease that are really, really important and big drivers of quality of life for patients and care partner burden. Another big factor here is the compressed appointment time, and this is a health system-wide challenge that there's so many different concerns and issues and not enough time to address them. And what that ultimately ends up leading to is a higher rate of patient portal use, essentially conversations that the patient or care partner can't have or doesn't want to have in the office get shunted into patient portals, patient phone calls, and some of these other kind of modalities of care that may or may not provide the same level of benefit for the patient. And simultaneously, this fragmented care really puts a lot of strain on care partners, often spouses or adult children of people with Parkinson's, who are sort of taking up a lot of the slack that our system is not fully providing for them. We conducted some qualitative interviews of care partners of people with Parkinson's disease through the Fox Foundation, and found that the biggest concerns were, care partners were having to leave paid employment, dropping out of school to be able to care for their parent or spouse with PD. I've put some sort of representative quotes here on the slide about the burden that this was having and the strain that this was having on care partners' mental health and well-being. In particular, there was one care partner who acknowledged that she had suicidal ideation multiple times while caring for her husband, and had not mentioned that to the husband's neurologist or to her own doctor because she was afraid that then they would put her in an institution and leave her husband alone at home. So this really, I think, highlights the challenges that care partners face with Parkinson's. And at the end of the day, what we are looking at, what we care about is outcomes for people with Parkinson's. This map is looking at the geographic distribution of what's called potentially inappropriate prescribing. So for this in particular, this was looking at co-administration or co-prescription of a cholinesterase inhibitor together with an anticholinergic medication for people with a diagnosis of Parkinson's disease dementia. And again, there's a lot of variability across the country. Here in the Durham Health Referral Region, we're at about 42% of people with PD dementia are getting both a cholinesterase inhibitor and a high potency anticholinergic, which should be a never event in the care of people with dementia. There's also evidence that people with Parkinson's disease have a much higher rate of hip fracture than the general population. And these two factors, the inappropriate prescribing or potentially inappropriate prescribing and hip fractures, are independent predictors of nursing home placement in people with Parkinson's. So if we want to keep people living well, doing well in the communities that they are in, we really need to figure out better ways of integrating and combining and improving care for people with Parkinson's disease. The American Academy of Neurology has put together these quality measures for Parkinson's. There's sort of 10 measures that run through things like an annual diagnosis review, various medication-related complications, contraindicated medicines, rehab referrals, and so on. But when you actually look at how well we as a movement disorders society or movement neurologists across the country are performing on these measures, it's really not great. The diagnostic review is documented in only about 7.2% of people nationally. Psychiatric assessments for like mood disorders, psychosis, and impulse control disorders are about 16.6. Dysautonomia is probably doing the best. In about 2/3 of patients have a documented vital signs, orthostatic vitals. Falls assessment, which was recently taken out of the official quality measures, but I think is still a very important quality measure for people with Parkinson's. Falls assessments are happening in only about 1/4 of people, and advanced care planning in 1.3% of people with Parkinson's disease, which is really unfortunate in this condition, which we know is chronic and degenerative, and where people really need a lot of palliative support and early advanced care planning to make sure that their wishes and desires are known. So there's a lot of room for improvement across the country in taking care of people with Parkinson's with high quality, high value care. So I hope I've convinced you so far that our standards of care, our current model for Parkinson's, is a very leaky pipeline with a lot of different areas where people might sort of fall through the cracks and not end up with the high quality care that people with PD really deserve. And so one thing that we've done here at Duke to try and mitigate some of these factors is develop or expand a novel or a new care model for folks with Parkinson's. We're calling it the Benchmark Clinic or the Thrive Clinic. I'm trying to move people towards this new mnemonic for transforming health and resilience through interdisciplinary and virtual engagement for folks with PD. And our model, as you can see on the left here, is really one where the patient is at the center. And then we've got all of these different specialties and specialty support sort of surrounding the patient and their family to sort of help them through this diagnostic journey. Integrated and interdisciplinary care for Parkinson's is, in my opinion, really sort of the way of the future. It's known to be effective in other neurodegenerative conditions. Here at Duke, like at many other places, we have a thriving Huntington's clinic and ALS clinic. And it's been, sort of rolled out in other countries for people with Parkinson's. In particular, in the Netherlands, they're probably the world leaders in thinking about care in this way. They have essentially a hub and spoke model of regional networks where they have one center of expertise, I believe located in Amsterdam, and then these regional networks that folks are connected to. And so you can see that, in this model, they've got the center of excellence in the middle, and then the patients around the outside. What we want to try and do is think about, can we flip that and put the patient really at the center, and the rest of us kind of around them and supporting them. But the Netherlands model really found that they had a significant reduction in hip fractures and hospitalizations for people with Parkinson's, and an average cost savings of about $400 US per patient per year. So pretty impressive. Obviously a lot of legwork to get this network set up, but some real payoff, both for patient care and for health system costs. However, the US is obviously not the Netherlands on a lot of different levels. Some big challenges that we face, I think, here in the US that perhaps they don't in the Netherlands is things like insurance fragmentation, about what services are covered and how much, and geographic distance, which makes some of this regional hub and spoke network perhaps a little bit more challenging to implement. So I want to spend the rest of my time talking to you about what we've done here at Duke. This is obviously the work of many, many people. This is just a portion of our interdisciplinary care team at our recent retreat. We were all smiling. Hopefully you can see that through the masks. But essentially what we've done is implemented a round-robin approach to this interdisciplinary clinic. Patients sort of rotate through these different stations and get really standardized assessments from PT, OT, speech therapy, social work, and pharmacy over the course of a morning. And then they get a lunch break while we do our team meeting before they meet with their neurologist at the end of the session as sort of a wrap up and to develop this personalized treatment plan. And because patients are getting these very standardized, validated assessments across the course of the morning, it also serves as a sort of a benchmarking, if you will, in terms of how well is this patient doing, or are they doing as well as they can, and what can we do to get them to achieve those higher up benchmarks. So you can see the sort of overall clinic flow on the left. We ask the patients to arrive by 8 o'clock. The clinic proper starts at about 8:30. So that gives us a half an hour sort of buffer window if people are running late. And they spend about 45 minutes per station doing these different assessments. We give everybody a written after visit summary for each station, which includes some really specific recommendations in this nice sort of green to red spectrum on how well people are doing compared to where we would like them to be. It's been really successful both in terms of patient satisfaction and patient rating of our interdisciplinary teamwork. This was some data from the pre-COVID in-person clinic. One challenge that we did face, however, was that there was a relatively high rate of cancellations or no-shows, which was pretty concerning because we had a long backlog and a wait list for this clinic. So when people don't show up, that's a lot of visits that they're missing and space that we could not use for somebody else. And so one of the social work interns with us in 2019 did sort of a quality improvement review of the first 6 months of the clinic. You can see here what the different potential reasons for cancellation or no-show were. In particular, the relatively long appointment time and time conflicts with perhaps other clinics was a challenge for many of our patients. On the right, you can see the geographic distribution of where people were coming from. We are marked at Duke. We're here in this little yellow dot, kind of right in the center of the state. And then you can see that we had a fair number of people from our immediate area, Wake County, Durham, and Orange County, where Capitol Hill is located. But then really a spread, all the way from the coast into the mountains, and a number of people from the Charlotte region, kind of the southwestern corner of the state. So in response to this quality improvement project, we started to implement some changes in the way that we were reminding people about the clinic, calling them in advance, and making sure that they knew what to expect when they arrived. Right as we were starting that that second phase of the quality improvement project, the COVID-19 pandemic hit. So we really had to pivot quite quickly. We, as you can see, we opened the benchmark clinic in July of 2019, and that QI project ran for that first 6 months. And then, of course, in the spring of 2020, we had to shift very suddenly to a telehealth model, like everybody else did. One thing that we did for telehealth was split up the day a little bit. So in the first half of the week, patients were receiving phone calls from social work and pharmacy to complete those assessments. We left the therapy assessments on Thursday morning due to scheduling reasons. And then Thursday at 1 o'clock, Thursday at noon was our interdisciplinary team meeting, followed by the neurologist wrap up. But we did try to split it up a little bit just to prevent screen fatigue for our patients. And we remained in telehealth mode really for a little bit over a year. We spent quite a bit of time building a database to be able to track people over that telehealth modality. And then we were able to, in the winter and spring of 2021, implement a virtual pilot program that I'm going to talk a little bit more about in a moment. We have now reopened for in-person as of August 2021. And so we have this nice opportunity now to sort of compare in-person and virtual in different ways. So one thing I do want to highlight is that the home locations of these patients really kind of shifted in the virtual format. You can see on the left here, this is the people who were seen in person pre-COVID, that same map, as well as some race and ethnicity data. And this is pretty reflective of our clinic population as a whole. We see about 10% Black African-American patients and a smattering from other racial and ethnic minorities. But one thing that we found when we shifted to virtual was, the geography was relatively similar, maybe a little bit more towards the coast, but we had a significant drop off in the number of Black and African-American patients who participated. And a lot of this has to do with internet infrastructure in various regions of the country and real disparities of, regions of the state, and real disparities in who has access to safe and secure high-speed Wi-Fi internet. So, the virtual pilot itself was really trying to look at a few different things, whether a virtual interdisciplinary benchmark clinic would have an impact on patient experience, on caregiver burden, on medication and therapy adherence, and lastly, on clinical outcomes like falls and hospitalization. So this was the flow of that 6-month pilot. We invited all patients coming into our clinic to the program, those who expressed an interest during their clinical visit with their neurologist were sent e-consent to a REDCap survey. So we had about 148 patients who expressed interest and were sent the REDCap. Of those, about 59 did start the consent form. You can see reasons why people ultimately decided not to in the flow diagram. We were unable to do this for out-of-state patients due to insurance reasons. So we really were kind of limited to North Carolina only. We had 59 people start the consent form, and 47 were randomized to either standard care, which was a regular meeting with their neurologist and potentially referrals to PT, OT, speech, and so on, or the interdisciplinary clinic. And so you can see the standard care and interdisciplinary clinic randomizations there. We did have some uneven dropout in the interdisciplinary care group, again, because of insurance and cost related reasons. Most people's insurances were covering visits with the neurologist, but there was a lot of variability in terms of who was covering virtual PT, for instance. And so we ultimately ended up with slightly unbalanced demographics of this virtual pilot. The data I have here is from the first several patients. We're still waiting on a few patients to fill out their post-clinic surveys, so I'm not presenting those folks here, but you can see that the demographics are a little bit skewed in that, the standard and interdisciplinary care groups were similar ages and disease durations, but interdisciplinary care was far more likely to have a care partner present, and this standard care group was a little bit more diverse and perhaps more reflective, actually, of our clinic population as a whole. And so what I'd like to present just in the last several minutes is some of our initial data on these patient and caregiver reported outcomes, as well as some clinical outcomes. Our primary outcome measure was the patient self-efficacy scale. This is a validated scale looking at sort of patient engagement and self-confidence and agency in managing various aspects of their disease. And you can see that there really isn't surprisingly much of a difference between the interdisciplinary and standard care group. Again, these are very small numbers, and I suspect we are probably underpowered to really detect a difference here. Similarly, for care partner burden, we used the Zaret burden inventory, which looks at various aspects of care partner strain. And again, very similar numbers between the standard and interdisciplinary group, with the caveat that, again, these are even smaller numbers for folks here. So I suspect that we are again likely underpowered to detect a difference. And so, one thing that we want to try to think about as we expand, hopefully, and continue to implement this interdisciplinary clinic is bringing in some pre-visit questionnaires, in particular, some standardized questionnaires on the motor and non-motor experiences of daily living, a palliative needs assessment, and something called a parallel chart, which is an opportunity for patients to write narratives to themselves that they can then turn to as their disease progresses, and sort of like a self-tracking, self-engagement way of engaging in one's care. There's also, I think, some really neat opportunities for real world assessments and sort of expanding this beyond the clinic walls, if you will, using things like activity trackers and apps to look at people's quality of life and activity, not just in the moment, but also, what are they doing on a day-to-day basis when they're out in the world. And lastly, some educational events, particularly if COVID permitting, if we're able to start using that 45-minute lunch break for some sort of lunch and learn type events, that might be a neat way to bring in some additional aspects. Nutrition and psychology are things that have been requested by patients who've gone through this program as areas that they would like to know more about. And there's also this big move in the Parkinson's Foundation towards a concept of family supporting families. So almost like a Parkinson's disease buddy program. Again, it's really hard right now because of COVID. We can't have people having lunch together. But if at some point in the future that becomes an option, I think that would be a really, really great way to make that the whole day as high impact and high yield as possible. So, in summary, I just want to leave you with these kind of three thoughts. That interdisciplinary care is both feasible and very enjoyable for people with Parkinson's disease. I do think that we need more data to really understand the impact of this on an objective level, as well as the cost effectiveness. If we think about expanding this or rolling it out more generally, what can we do to help mitigate some of that cost burden that I mentioned earlier? And then lastly, virtual care, I think, is for people with Parkinson's really something of a double-edged sword, because you do have an opportunity to really expand your geographic reach. But I think particularly what we found is that can come at this hidden cost of worsening disparities in care. So I think regardless of how we move forward with this, we do need to really pay attention to strategies to try and mitigate that unexpected disparity when we shifted to a telehealth only model. And so thank you very much for your time, and a massive thank you to all the people, again, who are involved in this. This is a pre-COVID picture of our, after our first day of the interdisciplinary clinic in July of 2019. And none of this work would have been possible without, not just the people on this slide, but also a number of other figures that are not seen. So with that, I'm happy to take any questions.
Thank you, Sneha. All right, I've got to ask the question. Is this financially viable, Sneha?
Yes, that is an excellent question. And I think, it is, but I think it depends on how you define financially viable. So it does increase people's engagement with the health system, gets them into, for instance, PT and OT and speech services that they may not have realized that they needed initially. So I think there are sort of system level cost benefit there. In that we're getting people into care when they wouldn't otherwise have gotten access to these services. There is a big burden on the part of the patient, though, which I think is really limiting the ability of some patients to fully participate in a lot of those services. And that's kind of, a bigger, policy level question about what to do with insurance and so on. But, patients, when they come to this clinic, are being asked to pay, up to 4 copays at a single visit. And, that can be hundreds of dollars for some people. One analysis that I was able to find of a similar clinic at Emory found that the overall cost of care for patients for that one was $2,000 for the visit, which is just not sustainable. Ours is probably, I don't have final numbers on ours, but it's probably not quite that high, but is still, I think, making it a challenging for us to really get access to where it's needed.
Thank you. Kim, do you want to ask your question?
Sure. Great talk, Sneha. And I think this is a wonderful care model. Definitely something to explore. I was wondering specifically about the social work piece. And how does the health system support a 45-minute appointment with social work? And does anybody pay for the clinical room space, or is the social work portion reimbursed by anyone?
Yeah, the social work portion is sort of funded through the Parkinsons Foundation. They're the ones who sort of support our social workers' time and effort. So that's through that. For the clinic room space, it's the patients are sort of in we essentially use a part of the side A clinic at Maureen Road. And so that clinic space was sort of negotiated with the Maureen Road folks about making sure that people had access in this one-stop shop type of a model. I don't know if that fully answers your question.
Catherine Moore.
I was just saying, perhaps the real benefit overall for the healthcare system would be improved outcomes like hospitalizations, facility admissions, things like that. That's difficult to quantitate and demonstrate for a number of reasons. One, these patients progress in their disease. Unfortunately, at this point, regardless of what we do, the procedure to collect that data can be very expensive or burdensome.
Yeah, I agree. I mean, I think that's really what they found in the Dutch model, is that the cost savings came from, the decreased rate of falls, the decreased hospitalizations, but that is a longer term, I think, benefit.
Kevin Van Landingham?
Yeah, two questions. First one's pretty quick. Did you look at the difference in the no-show rate? I realize there's a potential difficulty in doing that by video, but in terms of attendance to clinic visits long-term. And the second is a little bit more interesting to sort of entice the insurance companies into reimbursing for all of this, is to video these individuals. And I realize you've got a ton of privacy issues and massive data components to all that, but snippets of it to compare the two groups to demonstrate whether there's better compliance, less stress. They're not up all night trying to get to the clinic if they're driving hours away and things like that could affect their performance, to actually demonstrate a benefit of managing patients this way. I think insurance companies, they'll respond to that. So
that's a really good point. We did not include recording of the video when we did our virtual pilot. We do have recordings, consented recordings. When we were doing stuff in person, we were recording a portion of their physical exam. But ultimately, we felt that with the video remote recording, that was going to be a data privacy sort of challenge. But I think that having that, that multiple quantitative measurement of people's activity over the course of, say the week before and the week after their clinic, perhaps is a really, really nice way to again demonstrate some objective benefit. Like, we know that patients and families really enjoy this clinic. It's really highly rated. It's got a long wait list to get in. But I think you're right. We do need to figure out, what types of objective measures are really going to be able to move the needle and make this and turn this into the standard of care. And on your no-show question, we did sort of look at the reasons for either dropout or not participating in the virtual pilot, and it was almost entirely insurance related. Partly people who live out of state could not get virtual telehealth for PT and so on. Some insurance companies, as I alluded to, were not reimbursing at all for virtual therapy services. And the last reason was big internet infrastructure differences and kind of patient comfort with the idea of virtual PT and virtual OT.
Sneha, I'd encourage you to do a real business model with JT, to see how the finances. I mean, I hadn't even I hate to say this, but I hadn't even thought about the patient finances. I was wondering more about the department's finances. But I would encourage you, because if there really is some cost savings or some benefit, we might be able to get the health system to try to invest in it. And the other thing is, did you learn anything from what Rick Bedlack was doing in the ALS clinic? Have you seen his operation?
Yeah, a lot of what we've done here is sort of modeled in part on the ALS clinic and in part on the HD clinic, since those were our two sort of established multidisciplinary clinic models. One of the things that we really want to try and do as part of this is develop this sort of benchmarked database and so sort of quantitative measures of people's performance on these scales over time.
Allison Allen, you had a comment?
Yeah, hey, I'm Allison. I'm one of the social workers and the coordinator on the project. I just wanted to add that I think that the barrier of the patient cost, or emphasize, because Sneha did say this, the barrier of the patient cost is underrepresented or underreported. We can't capture that because those folks simply don't schedule. So we don't really have a way of tracking the folks that drop out from the beginning.
Thank you. All right. Well, Sneha, that's the last of the questions and comments. Thank you so much for the talk and for all that you do, both for our department and for the Parkinson's patients who come to Duke.
Thank you all.
Everyone have a great day.
Bye.